Hello, everyone, and welcome to today's webinar, Optimizing GI Testing, Molecular Diagnostic Testing for Common Stool Pathogens. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by BD. BD is a global medical technology company that is advancing the world of health by improving medical discovery, diagnostics, and the delivery of care. To learn more about our sponsor, please visit moleculardiagnostics.bd.com/bd-max-system/. Now, before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab down at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located at the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Margie Morgan, Professor of Pathology and Laboratory Medicine and Scientific Director of the Microbiology Laboratory, Cedars-Sinai Medical Center. Dr. Morgan has over 30 years of laboratory experience, first as a bench technologist and then laboratory director. Her professional focus has been antimicrobial stewardship, Clostridium difficile diagnostic strategies and infection control measures, and application of molecular methods to the microbiology laboratory. These interests have led to over 100 abstracts and publications. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Morgan, you may now begin your presentation.
Good morning, everybody. I'm Margie Morgan. I work in Los Angeles at the Cedars-Sinai Medical Center in the Microbiology Department. And I thank you today for joining me for this webinar. My objective today is to share our experience with you with switching from manual to molecular methods to detect GI pathogens. So for the next 50 minutes or so, I'll tell you our laboratory story. If I do not answer all your questions during the presentation, there should be time at the end for your questions. So my presentation is about optimizing GI testing, molecular diagnostic testing for common stool pathogens. So let's get started. The primary diagnostic challenge, of course, is about diarrhea. And diarrhea is really quite important. It's a common reason to visit a physician. There's symptoms for many pathogens with varying degree of seriousness and that can have similar symptoms. So this disease can also be a particular concern for children and immunosuppressed who are at risk because they're, of course, at a greater risk for fluid loss due to diarrhea. But, you know, it's always challenged me and laboratorians and physicians about what really is diarrhea. Well, it's defined as greater than or equal to 3 loose watery stools in a 24-hour time period. Test ordering patterns by physicians tend to be somewhat random. I know they certainly are in my institution, and I assume they probably are in yours as well. And sometimes it's not based on patient's history or current practice guidelines. It's just a patient shows up with diarrhea, and let's just take the attitude of let's just look for everything and see what you might have. And then sometimes a person may not be all that ill and in an outpatient setting, and we question that is laboratory testing even necessary. So yes, diarrhea is a diagnostic challenge. We have had some help over the last year or so. There are some new IDSA guidelines that were published in 2017. And this can provide us some very, very useful information in the laboratory, and also, of course, very good information for clinicians to maybe they can better understand the proper ordering of tests for diarrhea. Some of the key points that are in these guidelines is there's clinical symptoms and patient exposure history or risk factors that should guide the help of acute gastroenteritis diagnosis. They're also recommending molecular tests for the most relevant bacterial, parasitic, and viral enteric pathogens. They also really harp on that diagnostic testing should be more selective and limited to settings in which the tests are more likely to provide clinically useful results. We need to think about the history, where has the patient been, and think about the individual tests or groups of tests that should be ordered. Perhaps we shouldn't head toward ordering large syndromic panels. Are they clinically relevant? Are all of these diagnoses unnecessary? And we need to think about the impact on healthcare costs in the massive ordering of kind of shotgun approach to diagnosis of diarrhea. Further looking at the guidelines, we can see they look into exposure or the condition associated with the pathogen causing diarrhea. And they kind of separate it into three groups that could be helpful to clinicians and to laboratories in developing algorithms for the diagnosis of diarrhea. And by looking at this, you can see it's divided into community-acquired, foodborne, traveler's diarrhea, the nosocomial issues such as C. difficile, and diarrhea that is perhaps more chronic in nature or has an unusual travel history or unusual exposure to contaminated water. So we can use these guidelines to really help us in trying to prepare diagnostic algorithms and guidelines that can maybe help clinicians more selectively order laboratory tests so we are not so bombarded with just massive pan orders for many, many pathogens. So all of these diagnostic tests are supposed to be very helpful, and they are particularly helpful with the endangered. In the endangered, I include the children that are younger than 5, elderly, immune compromised, patients that have bloody diarrhea, severe abdominal pain, or certainly those with signs of sepsis. It's also very helpful in the use and selection of proper therapy, that being mostly antibiotics. Also, it can help to know if anti-motility agents are appropriate for use. If hospitalized, of course, we worry about contact precautions. Also, we could limit further testing by doing a good laboratory diagnostic testing by preventing further workup, and it could be a cost savings for the hospital and also a cost savings for the patient. Also, we can assist with public health outbreak investigations. I've worked in the laboratory for a very long time, and I've done many decades of laboratory testing for stool cultures and for ova and parasites. I've always thought we've tried to do a very good job. We've tried to be very sensitive and specific, but I have to admit, some days may be better in my judgment on the bench than others, but generally I thought we've done a good job with sensitive and specific testing. But I've always thought that stool cultures were labor intensive. It can take 3 to 5 days to produce a final result. O&Ps, I have to admit, they were not always my favorite thing to do, and I think I share that with the people that I work with in my own laboratory. You have exposure to chemicals. It's a lot of labor involved, and you have a lot of interpretation that requires a good deal of skill. You can also have excessive ordering patterns of stool pathogens testing by physicians paired with less than ideal test options. And this can lead to problems in the clinical laboratory where you're just getting lots of tests and duplicate tests and repeat tests for all different kinds of pathogens. And unfortunately, laboratorians can spend a good deal of time working up negative stools, which can account upwards of 95% of the stool samples submitted for testing. This is just looking at what we all know is the standard manual bench processing for the bacterial cultures that we receive for stools. We have a variety of incubators that we have to incubate into after we set up the specimen. We have plate reviews. We have to subculture many colonies. We might have other tests to perform, such as EIA tests and such as well. And a lot of times, this is not a 24 to 48-hour process. This could go to 3 days or longer for all the subculturing, the workups of suspected pathogens, the possible susceptibility testing, and preparing organisms for the send out to public health department. So this could be up to 72 hours in time, and of 20 stools, we're lucky if we have one positive with all of this work. If we look at it in a more grander scale, it's really kind of alarming sometimes in how many plates and different tests and different types of equipment that you have to have just to do a routine stool culture to its utmost in your laboratory. So that's what this slide shows, just all the different kinds of plates, incubators, different kinds of kits, and readers that you might find necessary in order to do a stool culture. So yes, it is a bit complicated. So one question, does this all make sense? Well, how about the cost of all those things on that last slide? There's lots of agar plates, broth tubes, and antigen tests. Not just the cost, but also the training, the competency records, all of the QC records for all of these tests have to be maintained. Equipment. We have multiple incubators at different temperatures, EIA readers. We have to produce the data, but is it possible that performing a molecular multiplex assay might actually reduce the total cost when compared to the cost of all these labor-intensive methods that we do in a manual stool culture? Then let's think about the labor that I've outlined in those last two slides. There's many steps, and there's lots of CLS hands-on time in performing those steps. There's a lot of screening out the normal flora to find a pathogen. And there's incredibly few positive findings for the amount of work and all of this media and equipment that I have. So the significance, well, there's a great deal of work and time trying to be very helpful, but actually we're delaying diagnosis. Sometimes we don't have significant results until 72 hours or longer down our pathway. There's also safety concerns. If we're dealing with pathogens out in our laboratory on the bench, we could have many bacterial isolates being sent around the laboratory for different testing methods, and this is a potential safety concern. So how about the value of molecular testing in dealing with all of this? Well, molecular testing can give us a blend of speed, accuracy, and also multiplexing capabilities. With the speed, we can have faster time to result than traditional culture methods. We can do a very highly sensitive and specific way of testing, and we can examine a number of targets concurrently without having multiple plates and pieces of equipment. But there comes some key questions when we think about switching to molecular testing. Does molecular testing for fecal pathogens really improve patient management? Are there certain situations or patient populations where a molecular or multiplexed approach is particularly valuable? And how does this cost figure into all of this analysis? And so this is some of the things that we will be discussing in future slides. First off, does molecular testing really improve patient management? Well, if you look at a therapeutic standpoint, rapid testing for stool pathogens using molecular testing, I think it makes sense. You can inform patient management decisions and help minimize the use of inappropriate or unnecessary antimicrobials. Things like this can be especially important when it comes to the detection of Shiga toxin-producing E. coli, where if you had continued antibiotic exposure, you might increase the risk of the patient developing hemolytic uremic syndrome. You have more rapid diagnostic information for the severely ill patient. And I think a very, very important point in these days with increasing healthcare costs is if we can provide a very rapid molecular identification of a pathogen, it would eliminate further downstream testing, such as colonoscope procedures, when the slow turnaround time of our conventional diagnostic methods had not found a pathogen. So I do think molecular testing does improve patient management. Also, molecular testing can assist in public health. From a public health standpoint, rapid testing for stool pathogens using molecular testing makes very good sense. We have more rapid alerts for outbreak investigations, such as finding Salmonella, Shigella, and Shiga-producing E. coli much more rapidly. And we certainly help out our infection control practitioners by finding these organisms much faster, which can lead to proper infection control measures to be taken more quickly in the hospital, or even in reporting these to people that work in such places as long-term care or in daycare facilities. But we come back to cost. So let's look at how does this cost figure into molecular stool testing. These figures are, of course, from a publication, and all of us would need to look at this closely in our own laboratories and see how this cost breakdown works for them. So they compared the cost of conventional culture to the cost of using the BD-MAX system for doing molecular testing for enteric bacterial pathogens. And as you can see in the breakdown in minutes, the conventional culture takes far longer. The supplies are also not minimal. We talked about all the plates and different instruments that are required. And then the labor, I think that's the thing that's most outstanding with a conventional culture, is how many minutes it takes to set up. Supply costs and then total cost. You can see when you put all this together that molecular testing really does not increase your costs that greatly. There's many molecular assays for pathogen detection, and whenever you're looking at moving in this direction for your laboratory, you need to look at all of the options and see which one would work best in your laboratory. Multiplex molecular panels are very well suited as a diagnostic platform for stool pathogens. They can target select enteric pathogens and provide very rapid, valuable results. There's assay options available from many different manufacturers, and you need to take a look at all of them and see which one would best fit in your laboratory situation. They differ in multiplex panel size. They have bacterial, parasitic, and viral targets, and some of them offer more flexibility in testing than others. Most are sample to result automation with rapid turnaround times of around 2 to 5 hours. All of these tests will improve your workflow efficiencies in the clinical laboratory. And let's take a look at that in a moment. The first question is, why did we choose to use the BD-MAX system? We did look at all the methods available, and we thought that the BD-MAX fit best in our laboratory. It targeted the most common enteric pathogens. It met our desire for flexibility within a multiplex testing format. We were able to selectively test what was ordered by the physician. Hopefully they're using our algorithm, which is based on symptoms and epidemiology of the patient. We very much needed a separate C.difficile testing panel. We thought that was very important for our inpatient population. We also thought it was important to be able to separate out enteric bacteria, virus, and parasitic testing, because in our developmental algorithms, we have it selected out for certain patient populations to only be tested for these in certain situations. Also, the patient billed less with a selected target panel testing. Most of our testing in our laboratory is on outreach, outpatient type testing. And so we thought being able to bill separate panels and selectively testing these panels was the best option for us. The BD-MAX system is easy to perform. It has batch testing capability that met our volume needs. We do quite a few of all of these per day, and our laboratory costs were within the expected range. I'm going to go through all of the enteric pathogen panels and talk about some of the pros and cons and different things involved. And I'm first going to start with the BD-MAX Enteric Bacterial Panel. This panel detects pathogens that cause most of your enteric pathogen bacterial disease, over 95%. So this may be the only panel that you need to test. It detects Salmonella, Campylobacter, Shigella, and Shigella toxin-producing organisms. Let's look at those stars that I have by Shigella and Shiga toxin. I want you to note that the Shigella species primarily targets Shigella, but it can also detect enteroinvasive E. coli. The Shiga toxin-producing organisms, that is the primary thing that it is detecting, but it can also pick up Shigella dysentery. It is very helpful that this has been FDA cleared for both the testing of fresh stools or for Kerry-Blair transport. The MAX Enteric Bacterial Panel certainly improves laboratory workflow compared to culture. This was a very interesting article that was written by Dr. Mortensen and his group, and it shows that all the different steps of mapping a culture, it's really kind of amazing when you think about all the steps and all the movement around the laboratory that you have associated with a culture. And when you compare a manual culture to BD-MAX, you would see that BD-MAX has an 82% reduction in decision steps compared to culture. And so you have far less problems to deal with and far less workflow issues to deal with. So it really makes for a very efficient system to use the BD-MAX Enteric Bacterial Panel. This is how simple the specimen prep and operation is. You first start off with adding a specimen to the sample buffer. And as I said prior, you can use a fresh stool or a Kerry-Blair stool specimen. You have to vortex the specimens once it's added to the specimen sample tube, and then add to the rack. The strips then need to be loaded into the rack. You have a reagent strip that contains your PCR reagent snap-ins. That is in your sample rack that is placed into the BD-MAX. Then you place a PCR cartridge in the reader, and you're good to go. So it's really about a 3 to 4 step process that's a very simple process to follow. We perform all of our sample specimen processing in a biological safety cabinet, and I think even though this is a very simple specimen prep and operation, I cannot overly stress the ability for all of the molecular methods used in microbiology of having a very strict sterility protocol and making sure that you're doing the test at the best of your possibilities. So once you have everything set up in the instrument, you're ready to go. You can do batch mode testing, so you can do up to 24 individual tests per run, and you can do 86 specimens in like a regular 8-hour workday. The hands-on time for those 86 specimens would only be about an hour and a half. You do not have to run 24 individual specimens. You could run 3 on a run. You could run 12 on a run, but you can run up to 24. Of course, you have to do quality control in any molecular process. There is an external positive and negative control that must be done with this assay. Of course, you can do daily QC if you wish, or you can do an IQCP type plan and have a designated frequency established for doing your QC. This is a nice multi-center evaluation that was done by Dr. Harrington and the group on the BD-MAX Enteric Bacterial Panel. It's a very nice paper showing their evaluation of this panel. They compared the panel to the routine culture and to an enzyme immunoassay for Shiga toxin and showed very good comparative results in this publication. It's a very large multi-center evaluation with thousands of specimens, and I think if you want to read more about how they went about doing their testing and their findings, this is a very good reference for you to go to. I might just address some of the overall performance data in these charts just to let you see how robust this assay really is. You can see the top is the overall perspective, the bottom part is the overall retrospective performance data. This chart has both unpreserved and Kerry-Blair specimens, and you can see for both types of specimens, there is a very good agreement. And in the paper that was written by, that I showed previous slide, there was not that much difference between unpreserved and Kerry-Blair specimen testing. So that's really up to your laboratory to decide which one and which way you want to go, or use both in your testing. And you can see this is a very robust assay for detecting these pathogens. Next, I'm going to talk about the extended enteric bacterial panel. This detects 4 organisms that you can see listed on the left-hand side. It's Yersinia, E-tech, Plesiomonas, and Vibrio species. Now, this extended enteric bacterial panel is up to you to decide how you would like to use. You could routinely use this on every specimen if you so wish, and you think that falls within your select guideline for testing your patients. Or perhaps you could be a little bit more flexible in your usage. This is the way we went in our laboratory. We did not think that we needed to test these pathogens on all of our stool, and we educated our clinicians and have given them the opportunity to add this on to their order, but we do not routinely do it on every specimen. We think that this testing on these unique pathogens should somewhat be based on the patient status, the history, and clinical presentation, rather than just testing every stool specimen. But of course, this will vary with each institution, and you need to make the decision if this should be an extra add-on or if you want to do it routinely on all stools. This is a very nice multi-site evaluation of this assay for your perusal to see how this assay performs. And you'll see that it's a very robust assay and a very good assay for the detection of these unusual stool pathogens. There is one thing I want to make sure that you are aware of. You do not individually test the extended bacterial panel. You actually have to test it along with the enteric bacterial panel. It is a snap-on add-on to that panel, and you do it together. So it's one sample, one setup for the 8 bacterial pathogens. This is also some more information showing you what a robust assay this is as well. This is from the BD MAX Extended Enteric Bacterial Panel package insert, showing you for the unpreserved and Kerry-Blair specimens. Both of them give you very good sensitivity and specificity of the assay, so it's up to you which specimen type that you want to test. And as I said, this makes a very good add-on test for pathogens that we've always had somewhat trouble in our laboratory to detect, and you need specialized methods and some specialized skill to look for. So I think this is a very, very nice addition for those unique patients that need to look for these pathogens. This is really a very nice way to look for them. So let's go through over some questions that you might have about this assay. How are we using the BD MAX extended enteric bacterial pattern? Well, we use it as a flexible option for a more complete panel, as I said, for those patients requiring such testing. Now, in our laboratory, we haven't seen these pathogens very often that are in this extended panel, so we didn't see a need in our algorithm to have it tested on every specimen. But as I say, this is a decision that every laboratory needs to make. And so I will just reiterate at the bottom of this slide, I said that you do really need to develop an algorithm, and you need to educate physicians to order both panels when needed. And you add-on requests are problematic, so you can't individually add on an extended bacterial panel. So as difficult as it can be, we do need to provide education in our algorithms to our clinicians so that they're sure that they order the proper things. Do we perform susceptibility testing on Salmonella and Shigella? Well, we might be a bit of outliers, but yes, we do. And it was not a decision made by the laboratory alone. We perform susceptibility testing on both Salmonella and Shigella species because this was a request that was made by our infectious disease physicians. This is something that you need to discuss with your clinicians. Do they need susceptibility testing? They may need both, they may need neither, or perhaps they only want Shigella tested. But this is something that you need to discuss with your own physicians in your own institution. Next question, are you always able to subculture organisms? Well, we subculture all our positive Salmonellas and Shigellas from the submitted Carey-Blair vial onto McConkey, HE, and selenite broth if needed. And no, we're not able to subculture 100%, but we do subculture most, if not all, the Salmonellas. We're currently averaging around 97% and somewhat less of the Shigella. Sometimes also your subcultures will have low numbers of colonies, so you need to really be on guard to look for low numbers of colonies from your Carey-Blair. Do we send an aliquot of Carey-Blair medium or an isolated organism to the public health department? Well, this brings up a very important point. If you're switching from your standard manual type microbiology for stool cultures to use molecular testing, you really do need to let your public health department know because they might start seeing some different submissions from your laboratory. So you need to talk to them about what their expectations are for your sending of organisms to them. Our public health department in Los Angeles instructed us to send Salmonella and Shigella isolates on agar slants when possible. If we are not able to culture a positive molecular test, we are then sending a Carey-Blair medium aliquot to them. For Shiga toxin positive specimens, we were instructed to send a Carey-Blair medium aliquot that was frozen. As I said, this is what our health department told us to do, but yours might have different suggestions for how you should handle this situation. Do stool specimens present problems for molecular testing? After all, it's poo, it's messy specimen. Is it going to cause a lot of problems with amplification? We've had very, very little problems with amplification. We've had very few so-called unresolved results. They do occur on occasion, well less than 1%, well less. There are various compounds in stool that could lead to this suppression of amplification that leads to an unresolved result and not produce a result. The most common interfering substance with most assays are lubricant solutions that are used for specimen collections. But we're kind of blindsided in the laboratory. We have no clue what might really be used for collection or be in these specimens. So we deal with an unresolved issue. But as I say, there's very low percentage and should not present you a problem. Have you had questions with physicians? Well, yes. There has been some confusion between Shigella species and Shiga toxin, and some general confusion with the presence of a Shiga toxin. What does a Shiga toxin mean? So we have had to educate some, even at the point of phone calls at the time of presenting the result to a clinician. But I think that's one of the roles that a microbiology has, is continued education. And I have to admit that not everyone is as informed about molecular testing as others. So yes, sometimes we do have to explain the results. We also sometimes just have to explain that molecular testing cannot be used for a test of cure. So what have I learned from these physician communications? Well, overall, I've learned that patient reports need to be very clear and informative. We've included an explanation paragraph with our molecular results explaining what the results mean. One could laugh and say, I'm not sure that anyone ever reads those, but let's hope that some people might, and we do feel that it's certainly necessary to provide some education about these newer methods, because I do think that a lot of clinicians are not necessarily informed. Before starting all of these assays, of course, we had educational flyers. I actually went to discussion groups, different meetings with our infectious disease and GI people to discuss this testing, talked to them, answered their questions. And even though this was beneficial and they thanked me for coming, and I'm sure you will go through the same process, I doubt if it will eliminate all your calls, but it certainly did help. But I do have happiness to present to you that even though you'll get some calls to start with, over time the calls really go down in numbers. And instead of getting calls to help them understand the test, you're going to start getting calls thanking you for a rapid result, and it was very helpful in the diagnosis. And I think as the final comment, I just have to say that for some reason, I know the reason, we can't know everything a clinician knows, and a clinician can't know everything that the laboratory does. And so basically molecular testing and results are really not understood by all clinicians. So whenever you're starting anything like this, one of your primary roles is going to be education. So let's move on to the MAX Enteric Viral Panel. Is there a MAX panel for detection of virus pathogens? I can say happily, yes. One was newly cleared in December of 2018. It's a 5-target panel that detects norovirus, of course the most common viral pathogen causing infectious diarrhea, and 4 additional pathogens of viral gastroenteritis. And some of those have varying degree of prevalence, certainly in your population. I'm very happy to have such a panel because we've been having to send these to reference laboratories for testing. So now we will be able to bring this testing into our own laboratory. The testing can be performed on unpreserved soft to diarrheal stool, or it can also be performed on Carey-Blair transport media. The stool preparation and testing is much like all of the other assays that are performed on the MAX. You use either the Carey-Blair or unpreserved stool specimen. With an inoculation loop, you will inoculate the sample buffer tube, and it will be vortexed and then loaded onto the MAX. I've not had the pleasure of doing this assay yet. We're currently getting prepared to start testing and doing our verification and runs and such for the viral panel, and we're very much looking forward to being able to also offer this in our laboratory. How does this test perform? Overall, it has very, very high test performance in both the unpreserved and Carey-Blair specimens, so is a robust assay and provide much help in the diagnosis of these types of pathogens. Next is the MAX Enteric Parasite Panel. What can I say about parasite laboratory detection that we aren't all just thinking about? It's, of course, the manual concentration for parasites is a very labor-intensive process. It has variable sensitivity. It can be quite tedious, and I think you do have to be very high skilled to recognize all the pathogens in the milieu of a stool. And overall, what is the sensitivity? Because we are looking at a very small amount of stool in a concentrated slide. So that makes you really do wonder what the sensitivity of these manual preps might be. There's also multiple methods that are required to examine a stool if you're looking for the parasites that are necessary. And some of these methods might have variable sensitivity and specificity. When we're looking at a slide, we're unable to tell the difference between Entamoeba histolytica and dispar. Also, it costs quite a bit of money for each case detected in both labor and multiple test methods. Also, as over there on the left-hand side, I've said a lot of people want to order multiple specimens. The standard has always been 3 specimens collection for patients, and so that adds to the volume in your laboratory and the cost because you're doing so many specimens per patient. And I don't know about your population, but in my population, we have a very low percentage of parasites. So it's really been a very big frustration for people in my laboratory. Although they greatly appreciate the science of parasitology and they think that it's an amazing science with all of the organisms and everything that goes with the detection of parasites, but they do so much work and they get so few positives that they don't really get very much reward in what they're doing. And that's always been an issue in our laboratory. So I have to say that the one celebration that we had in our laboratory was when we switched over from manual parasitology to doing molecular testing, because it was just really greatly appreciated by our technologists in our laboratory. This panel is designed to detect the common highly pathogenic parasites, Giardia, Cryptosporidium, and Entamoeba histolytica. And it does specifically detect histolytica, does not have the confusion with Dispar. You can, of course, use it for testing of parasites alone. It is an individual panel. Or you can use it in conjunction with the other panels, the enteric bacterial and extended bacterial and viral panel that I've already talked about. It does require one additional step in processing over the other panels that I've discussed. There is a preheating step for approximately 30 minutes to ensure that you're adequately extracting the DNA from the protozoans. You can use unpreserved stools for parasite exam and also formalin fixed. This has been very helpful, being able to use unpreserved stools. Even in the past, when we had adequate collection devices given to all of our clinicians for ova and parasite exams, it never failed that on weekly occasions, several times per week sometimes, we would receive a fresh stool for ova and parasite exam, manual exam, and we had to reject it due to its long transport time. So this gives us the capability of not rejecting those unpreserved stools. It can also eliminate the need for the less sensitive and complex methodologies, such as all the EIAs that we used to do for Cryptosporidium and Giardia to supplement our manual testing, which might have been insensitive. We also have less need for fluorescent microscopy, so you would not have to have those methods available in your laboratory. So I think this has really greatly helped us in our lab. This is a study that we did because we were so into the parasite panel, we decided to produce some of the good findings that we found. We've particularly liked having, as you can see in the upper left-hand grid, less exposure to stool, less exposure to the 10% formalin, and all of the stains and alcohols that are involved in the processing of parasitology. We also, of course, it eliminates scope reading. So you only have about 10 processing steps when you do a MAX Enteric Pathogen panel versus over 30 when you're doing a manual parasite exam. And hands-on time is over to the right-hand side. You can see the hand-on time per minutes per specimen. You have only about 2.7 minutes for a MAX panel versus 19 minutes per specimen for a manual parasitology exam. So there's an 85% decrease in hands-on time once you move to molecular parasitology. The performance is quite good in both unpreserved and formalin-preserved specimens, so I don't think that you'll have to worry about the risk of falling off in sensitivity from moving to an enteric parasite panel. So the question comes about, is this enough? Do MDs ask for additional testing? Well, no, they don't. But for some populations, additional testing might be required, such as outlined in your IDSA guidelines. if there's any outbreaks or unusual parasites moving around your community, such as Cyclospora. HIV, we might need to do more routine microsporidia detection. And if you have a lot of exotic travel, you may have to look for other parasites. We did maintain our manual O&P method in our laboratory for such requests, and also for unusual circumstances, and sometimes you just have that demanding physician that just wants everything done. But we've had a steady decrease in orders for manual O&P over time, and now we only schedule our parasite lab open about 4 hours a week, 2 hours 2 times a week, and sometimes we don't even need to have it open because we don't have any specimens to process. It has been a great labor savings for us. Another question, do we test the BD-MAX parasite panel ×3 like we did our manual open parasite exams? No, we are not doing it ×3. We feel that due to the increased sensitivity that we only need to do 1. We have ordering restrictions established and we consistently follow them, so we do not have multiple orders coming in for parasitology to our molecular laboratory. How will reimbursement policies affect enteric pathogen testing? Well, in our inpatient testing, the laboratory costs are perhaps more important than reimbursement amounts for this sector due to the single fee payments to hospitals. But outpatient testing, I think we have to be on alert. There's a lot of people with poor insurance plans that have evolved that place increasing payment burden on the patient. So we need to make sure that we're performing tests of value that actively play a role in the patient management. So in the future, we may need justification provided for reimbursement for such testing. So that directs one toward targeted test selection and testing. And also, as I said, it really targets our need to develop algorithms for this select testing so we can direct it if physicians are maybe not as good about choosing which tests should be run. And finally, let's talk about the C.diff panel that is near and dear to my heart. We've done a lot of work on C.difficile at Cedars, and so I feel somewhat comfortable talking about how do we test for C.difficile. Well, I think my first comment would be it's quite complicated. We've evolved from using nucleic acid testing alone into a 2-step algorithm which uses nucleic acid testing plus toxin A and B detection using enzyme immunoassay. Now, we might have a unique situation at Cedars, but we do a lot of work, investigative work in infection control with C. difficile, and we have a very, very strong stewardship program. And so we wanted to make sure that we could separate our patients that are colonized from our infected patients that required therapy. And also we wanted to make sure that we were properly reporting the correct patients to regulatory agencies. So we felt that using a 2-step algorithm with molecular testing plus an enzyme immunoassay was the best way for us to achieve this. So our 2-step algorithm at Cedars includes first performing a BD-MAX C.diff panel, which of course targets the toxin B gene. Now, of course, I'm sure you're quite aware that the toxin B gene is a very good way to detect C. difficile in a stool specimen, but you do not know at that time if it has active toxin. So the way we resolve that to know if there is a large amount of active toxin present is to perform a toxin AB enzyme immunoassay that is capable of detecting this active toxin. Our algorithm, we've been using it for over almost 3 years now, but it's been given validation by the publication of the IDSA clinical practice guidelines in 2018 that says this is one reasonable way to go about doing this testing. And these are the guidelines that can provide you some very, very excellent information about the proper performance of C. difficile testing using molecular assays. So the important issues that are in these guidelines is the physician-nurse education to improve patient selection and stool collection is a very important point. we need to make sure that we're only accepting stools which are truly diarrhea. So we're starting around with one of the first comments that I made in this presentation was we need to know what diarrhea is. And so we want to only test C. difficile on cases of unexplained diarrhea that are greater than or 3 loose stools per 24 hours. We've had an initial issue with laxative administration at Cedars, and so now we have a very ongoing protocol to try to make sure that stool specimens for C. diff testing does not have someone that has taken laxatives. Of course, they still have the guidelines for age testing, and now it's down to greater than or equal to 1 year of age can be tested. But at that age, of course, you have a very high prevalence of asymptomatic carriage, and you have to test with care. Children 1 to 2 years of age, you test cautiously. Older children, you can test when other causes have been eliminated. Our laboratory policies. We have rejection for repeat testing of specimens within 7 days unless new episode of diarrhea. And we do stool viscosity checks. Even though we have it written everywhere that it must be a diarrheal stool, we do a final check in the laboratory to make sure that we are truly testing diarrheal soft stools, and we prohibit the testing of formed stools. The best practice C. diff guidelines also say that we've chosen to go with the two-step algorithm. But if you have perfect stool collection and all of those things that I just discussed are in perfect form, you can do just nucleic acid testing or molecular testing alone. We do not think that we have the perfect stool collection in our laboratory, so that's why we moved to the two-step algorithm that detects the C. diff and presence of active toxin. So we have used the two-step with the MAX panel as our primary and the EIA as our secondary. But of course, the C. diff guidelines also say that you could use glutamate dehydrogenase as your primary test if you so wish. We feel that the molecular testing with the MAX panel has helped us better differentiate our truly colonized patients. And that's why we felt it was very important to maintain molecular testing as our primary test in our algorithm. And this is our diagnostic algorithm for the detection. As I had said, we primarily use the C. diff panel as our primary test, and if it is detected as shown on the right-hand side, we will reflex to the EIA. If it's PCR positive and EIA positive, we say that the patient is infected and the patient certainly requires treatment. If the PCR is positive and the enzyme assay is negative on the left-hand side of this branch chart, we say this patient is most likely colonized, and the physician has the information with the discretion to treat if they so feel necessary, but we feel that this patient is most likely colonized. So in summary, I presented that there's a variety of pathogens that cause GI infections, and they require an assortment of labor-demanding manual detection methods to identify the causative organism. Classic methods vary in specificity and sensitivity and are often randomly ordered due to a lack of physician understanding of these test methods. In comparison, if you decide to use a select multiplex molecular panel, it can enable your laboratory to test for the most common GI pathogens while providing improved specificity and sensitivity. But of course, physician education is necessary, and you need to assist with proper test ordering, and it's the time to start producing good algorithms for such purposes. Used properly, molecular panels are tests of value. They can supply cost-effective diagnostic tests for the significant GI pathogens that could have been undiagnosed using classic methods. And those are my final words, so I thank you for your attention, and now I'm ready to answer any of your questions or comments that you might have. Thank you for listening.
Thank you, Dr. Morgan, for your informative presentation. We will now start the live QA portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen and we'll answer as many questions as we have time for. Now, okay, Dr. Morgan, let's get started. Your first question is, what percentage of your stool orders are for all 4 panels versus single panels?
That's a very interesting question. I have to say that most of our orders are not for all 4. Our most common order is for the Enteric Bacterial Pathogen Panel, and I would say the next most popular would be the Parasitology. We get very few requests currently for the extended panel. Our clinicians were fully educated on such panel. I just think that perhaps in our patient population, using the guidelines and things that we educated on, they have not thought it to be all that necessary. So I would say we do about 20 a day of the enteric bacterial pathogen, about 10 of the parasite, and possibly 1 or 2 of the extended. We are just getting going on the viral panel, so I don't have any information to give you on that.
Dr. Morgan, was it hard to get physicians on board with a panel approach to diagnose enteric pathogens?
Well, you know, it ended up not being quite as difficult as we thought it was going to be. I did have my stewardship and ID team help me go to the hospital clinicians to help with education. We sent out some very simple flyers providing education to our outreach clinicians, and we talked to our emergency department doctors. They seem to like the concept of the organization of the panels, and we didn't really have much issue getting that started. On occasion, we do get callbacks to add on a panel, and I think that's understandable if something came up with the case that maybe they didn't expect. But we were very fortunate. We did not have a lot of problems.
Dr. Morgan, how does your lab facilitate the isolation of public health organisms, such as salmonella, before sending to your state or local public health lab?
Well, first off, you need to speak to your local public health lab. We were one of the first people in our community to start using molecular testing, so we really had to have some heart-to-heart and really sit down and talk a lot about it, because we didn't quite know how to do all of this. But now it's becoming more common, and you'll probably get a fairly canned response, I would think, from your public health department on what you should do. We do most of our testing from Kerry-Blair medium, so we do, as soon as we know that we have a positive Salmonella or Shigella on our testing panel, we will do a subculture from the Kerry-Blair. As I mentioned in my talk, on occasion, we do not recover an isolate. If we do not recover an isolate, we will then send them an aliquot of the Kerry-Blair. But that was with the understanding of our public health department.
Thank you, Dr. Morgan. Now, how do we decide which enteric panel to test on a patient?
Well, we do not decide, of course, in the laboratory. That's decided upon by the clinician. We did in our education, as I was talking before, suggest that they look at the guidelines for which panel should be used. I am available if there is some question by the clinician about which panel for travel or whatever circumstance they might want to order. But that's pretty much a clinician decision and not based in the laboratory.
Dr. Morgan, how would you recommend a small lab that sends out their O&Ps to incorporate the parasitic panel with send out of O&Ps?
I think that I understand this question in that it would prevent you from having to do a send out. Of course, the panel covers the 3 most common parasites. You might still have to send out a few things if the clinicians want to investigate other parasitic possibilities. But I think it's a wonderful option for bringing in your parasitology screening into your laboratory and preventing send-out tests. I think that would be a wonderful application of that enteric parasite panel.
I would like to thank our audience for so many great questions. We have so many coming in. We have time for just a couple more. But I do want to remind our audience that any questions we did not have time for today and those that are submitted during the on-demand period will be addressed by Dr. Morgan via the contact information you provided at the time of registration. So Dr. Morgan, let's fit in just a couple more. What if the physician insists on running C. diff on hard stool samples?
Oh, what a painful question. And you know, this early on when we implemented doing molecular testing, which is now about 3 years ago or so, I've lost track. It just seems like a blur. We had more issues with the rejection of stools and more calls from physicians. I remember one famous one early on when I actually sent a video of the stool as I shook it in the container to show the clinician how hard the stool really was. Sometimes clinicians don't see the patient's stool. The patient tells them they have diarrhea, or the nurse might say they have diarrhea, but by the time they collect the stool's solid again. So it's not just, sometimes, as I said, the clinician is unaware that the stool is corrected to solid. So if the techs get into issues with physicians and have trouble expressing their opinion about the stool, I'll take it over and talk to them and assure them that we were correct in that the stool is actually hard and that this is not appropriate testing per our testing algorithm. That's what we do.
Thanks, Dr. Morgan. And we'll wrap with this final question. How are you maintaining expertise for your cat parasitic challenges with your diminished microscopic time and training?
That's an excellent question and near and dear to my heart since our CAP inspection is next week, and we're very concerned with training and competency, of course, all the time. We never saw a lot of parasites to begin with. I'm based in the middle of Los Angeles with a very immune suppressed, non-traveling population, really. We don't have a traveling clinic or anywhere where we see unusual parasites. So we didn't get a lot of experience looking at parasites from doing patient specimens. We do still maintain our parasitology lab and still have ongoing processing. So the techs do still have ongoing competency and daily, at least twice a week, concentration of a few samples so they do not lose that ability. We, of course, do competency every year. We have CAP specimens coming to our laboratory, but that's the way we keep it up. But our prevalence of parasites was so terribly low, I do not believe that they received a lot of long-going competency from our patient specimens. So we try to do it for pictures, CAP specimens, and things like that to keep up their competency. I think that might
Thank you again, Doc. Oh. Yeah, sorry about that. Yes, that does conclude our Q&A. Dr. Morgan, thank you for your time today and your important involvement in optimizing GI testing. Do you have any final comments for our audience?
No, I just think that I guess my final comment would be we have really found a great ability to become more efficient, and we think provide very rapid and good results to our clinicians using molecular testing. It always has to be done in the best of circumstances with the best of sterility techniques. And I think if you really work to do a good package, you're really supplying very good information for the patient and at the same time making your laboratory far more efficient. And with that, I'll close.
Thank you again, Dr. Morgan. We'd also like to thank LabRoots and our sponsor, BD, for underwriting today's educational webcast. One more time, I'd like to thank the audience for joining us today and for their interesting questions. Again, we did have a lot of questions that we did not have time to answer, and Dr. Morgan will answer those following the presentation via email. Now, this webcast can be viewed on demand through August 2019. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. A quick poll will now pop up on your screen. Your answers and suggestions will help improve our webinar program and are greatly appreciated. Thanks for joining us. Until next time, goodbye.